Hey, welcome everyone. Um, my name is Dr. Punita Tandon, and I'm pleased to welcome you to the first webinar from our Liver in the Balance, Tackling Fatty Liver Disease in Primary Care webinar series, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. I'm a professor of medicine at the University of Alberta, co-director of the Cirrhosis Care Clinic, and medical director for the Office of Lifelong Learning and the Physician Learning Program. The program, the Physician Learning Program, and the Office of Lifelong Learning are committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. You'll see on the screen the land acknowledgement and the University of Alberta. Its buildings, labs, and research stations are primarily located on the territory of the Nihio, Niitsitapi, Blackfoot, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe, lands that are now part of the Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. Our next slide is on housekeeping information, and we'll just go through this briefly. If you could please use the chat feature if you have a question about any of the technical difficulties or L3 programs and services. I would encourage you to ask questions for Dr. Ma, and you can please use the Q&A feature of the webinar. You can review what's been asked and upvote the questions you would like answered. We'll try to get to all the questions we can, but if not, some of them may be answered in the next session. And a recording of the webinar will be sent by email to all who registered. Participants can claim CME credits and complete a personal development activity using the My L3 Plan tool. And for more information, you can visit the QR code. This activity has not been formally reviewed by the CFPC or the Royal College, but it is eligible for non-certified credit, and main pro participants may also earn additional certified credits by completing a linking learning exercise. Okay, now to our guest for today. I'm really pleased to introduce Dr. Mang Ma, who's going to present on liver in the fast lane, diagnosing, preventing, and understanding NAFLD, or now called MASLD. And Dr. Ma has been an important person in my life as training me as well as a hepatologist. And he's one of our most senior hepatologists and professors of medicine at the University of Alberta. He joined the Division of Gastroenterology in 1995. He's won numerous teaching awards and received the Excellence in Humanism Award from the Faculty of Medicine and Dentistry. He's received Distinguished Educator Awards from the from the Alberta Society of Gastroenterology, the Canadian Association for the Study of the Liver Education Excellence Award, and the Dr. Richard Fedoruk Memorial Award in Professionalism. And above all, he is such an incredible clinician and has a very busy practice in hepatology, where he focuses on MASLD and chronic hepatitis B, and he's helped to establish the first provincial management pathway for MASLD. So I'll hand it over to you, Mang. Oh, I'll hand it over to you, Mang. I think you're sharing your slides.
Thank you, Punita. I hope you can see my slide.
Yeah, you can see them, Mang.
So thank you for the invitation and the kind introduction. And let's see, I have no conflict of interest for this presentation. So the objective for this session would be get a useful understanding of steatotic liver disease from epidemiology to pathophysiology, assessment to management. And hopefully that will help you in the primary care setting, managing your MASLD patient. So I'm going to start with two cases. The first case, they are a typical patient you would see in your primary care practice. And the first one It's a 45-year-old gentleman with abnormal ALT for over 10 years. And common liver diseases have been ruled out. And alcohol use would be around 5 to 6 drinks per week. Type 2 diabetes, well managed, and also dyslipidemia, and he's on statin. ALT is mildly abnormal, AST 80, ALP 145, completely normal liver function, INR, bilirubin, albumin, slightly elevated ferritin, platelet count 150. So the second case is a 52-year-old female. Again, typically they have abnormal ALT for a long time. Also, common liver diseases have been ruled out. Very occasional alcohol use, also well managed. Type 2 diabetes and dyslipidemia. Slightly higher ALT, AST, but not that dramatically high. Again, normal INR, bilirubin, and albumin. Ferritin is 605, platelet count 250. So we have the only polling question I'm going to ask: who has more severe MASLD? Patient 1, patient 2, or you're not sure? So I'm going to go back to one slide just to help you. Okay,
Right
so
here in the result.
hopefully at the end, and I can help you to decide which patient should be referred to us. So there's definitely a strong connection between obesity and steatotic liver disease. The prevalence of obesity is quite scary. 1 billion people in the world living with obesity. And in fact, obesity is linked to 5 million deaths every year. It's really a dramatic cause of death in the world. And there's a change in the definition of obesity. And instead of using BMI, in general, BMI do correlate with body fat. But the new classification of clinical obesity is really excess adipose tissue with organ dysfunction or limit daily activity. Preclinical obesity means there's the presence of adipose tissue. However, there's no organ dysfunction or limitation in activities. However, the preclinical obesity is a marker for future clinical obesity if there are no change in the lifestyle or clinical management of these patients. So as I mentioned to you, there's really a strong association between steatotic liver disease and obesity. So this is the NHANES database, and when they look at over 13,000 participants, the overall prevalence is just less than 30%. And obviously, when you look at obese individuals, the prevalence is much higher. So when you look at obese individuals, 50% would have steatotic liver disease. Majority, they have some form of metabolic abnormality, whether they have dyslipidemia, diabetes, hypertension, or other metabolic syndrome associated condition. Even when you look at overweight, there's almost 25% of the participants would have steatotic liver disease. Again, majority would have some form of metabolically abnormal conditions. However, even when you look at someone with BMI less than 25, you still have 10% of the participants with steatotic liver disease. Again, majority would have some form of metabolic issue to go with it. Overall, you have essentially 1 in out of 4 participants would have fatty liver disease. So in order to connect the new definition of obesity to steatotic liver disease, I'm going to show you this, the only pathophysiological slide. So we all born with some fat cells. Those fat cells can be modified by genetic factor or genetic predisposition, some form of gene expression modification we call epigenetic change, the environment, lifestyle, alcohol use. And in essence, with weight gain, those fat cells become much bigger. And as the weight gain continue to increase, then now you're going to have angry fat cells that really develop this pro-inflammation environment that really causing severe oxidative stress in the body. This oxidative stress environment really not only affect the liver, but it affects essentially almost every single organs in our body. And for that reason, this really metabolic dysfunction related to this visceral adipose tissue increases is actually quite an important main pathophysiological mechanism in the development of steatotic liver disease. So this is the prevalence of overweight and obesity in Canada. As you can see, with time, almost 1 out of 3 adults would be classified as having a BMI over 35, and overweight would be around 35%. Taking together, 2/3 of Canadian adults would either have a weight issue or definitely would have a BMI over 35. So it's quite an important thing for long-term healthcare in Canada. So this is a study from Calgary, published by Mark Swain, and in their modeling between 2019 to 2030, we are actually not that far from 2030. And the estimation in Canada, there would be an increase by the steatotic liver disease prevalence would be increased by 20% to almost just over 9 million adults. As you can imagine, the cost to the healthcare and the society would be tremendous in about 5 years. With this increase in obesity and steatotic liver disease, you're going to see rising prevalence in cirrhosis, decreasing quality of life, increasing healthcare costs, increased society costs, and not to mention there will be a much higher need for liver transplantation, more cases of liver cancer that we will have to treat. So the contributing factor to obesity and steatotic liver disease, they're definitely a physiological determinants that is controlled by genetic predisposition, metabolic disorders, hormonal imbalances. Stress has something to do with it, depression, anxiety, sleep disturbance. There's also a behavioral determinant, dietary habits, physical activity, lifestyle. However, they are also social determinants. our ability to get healthy foods and the socioeconomic status, social stigma, discrimination, all can play a part in contributing to obesity. There's also government policy and the willingness to provide uh, support to preventive care, education, and the government is also influenced by a lot of commercial interests. So all those add together, causing what we currently see, this increasing prevalence in obesity and steatotic liver disease. So this is just to summarize. So you start with a healthy, shiny looking liver, and with genetic predisposition, lifestyle, now 1 in 3, 1 in 4 adults would have fatty liver, and then 1 out of 20 will have steatohepatitis with fibrosis, and 1 out of 100 would have cirrhosis. And from cirrhosis, they go on to develop cirrhotic complications, liver failure, and liver cancer. So this changes on histological slide would be normal looking, full of fat. Now you get fibrosis, and then you get cirrhosis. Now, typically we said in the old literature, it's a very long endurance disease, gradually progressing to cirrhosis in many years. But that has also changed in the last 10 years. So in order to further classify steatotic liver disease, this is the current guideline. So majority would be metabolic associated with steatotic liver disease. They have metabolic dysfunction, and when the dysfunction becomes severe, they have steatohepatitis. In some people, there's a component of alcohol consumption contributing to the steatotic liver disease, and we call that MASLD. And how much alcohol consumption is actually also being taken into account. So if they have 1 or 2 drinks a day, and that would be predominant just metabolic associated. If they consume a lot more alcohol regularly, and that would imply 3 or 4 drinks a day, and that would be alcohol predominant steatotic liver disease. Obviously, you have pure alcohol associated liver disease. There are other conditions that can give you fatty liver also. So this would be the most up-to-date classification of steatotic liver disease. So a lot of people think, what's the big deal about fatty liver? Fatty liver is really important in the sense that the more severe the fatty liver is, the more likely they have fibrosis. And once they have fibrosis, that will predict ongoing injury to the liver, and eventually they will get cirrhosis. So the initial diagnosis, the degree of fibrosis, predict the likelihood someone will develop cirrhosis and cirrhosis complication. The higher the initial fibrosis stage, the more likely they have high risk of liver-related mortality. So the degree of fibrosis predict the liver outcome. But fatty liver is actually much more than that. When you look at different stages of fatty liver, and as we mentioned, the fibrosis stage predicts severity of liver disease. The more severe the fibrosis stage, F4 means cirrhosis, the higher the likelihood they are going to die from severe liver disease. However, when you look at overall mortality, this severity of liver cirrhosis also contribute to overall mortality. It's just a reflection of how much oxidative stress the body is being exposed to. And this oxidative stress can do many health damage to the body. So fatty liver is not just a liver disease, it's also a marker of many health issues. So if you look at mortality in follow-up someone with no fatty liver, obviously we all have some kind of health conditions that will lead to severe health issues and death. So if someone has no fatty liver, and the death rate would be very low. If someone with fatty liver and in association with obesity, now you have this oxidative stress, and that increase not only if they don't have diabetes, they're going to get diabetes. They have high probability of getting heart attack, all kind of cancer risk, and many other health issues. If they have obesity and steatohepatitis at the same time, now the liver cause associated mortality will increase also. So if someone would have a weight issue with no fatty liver, and they actually have a pretty good long-term outcome. Once they have obesity and fatty liver, and although the liver-related cause of mortality is low, but overall cause of mortality will increase. And when they have significant fibrosis, now the liver-related mortality will go up with the rest of the mortality also. So fatty liver is actually a marker of really severe metabolic stress to the body. So obviously, as a hepatology, we only deal with the liver-related mortality. In the primary care level, you have a lot more to address. So this is just another study looking at if you have no steatotic liver disease, the long-term survival probability is actually very good. Once you have MASLD and you drop significantly, go back one. And when you look at alcohol-related liver disease, and this obviously the alcohol can create all kind of health issues, and even in alcohol liver disease, and there's a trend that you will fall somewhere between just steatotic liver disease and alcohol-related liver disease. Now, this is actually the future, what we call tailored medicine. So this is a very interesting study. And so this look at genetic contribution to liver-related events. And those are the genes that are associated with severe fatty liver. And when they look at big biobank study and 9 years follow-up, risk of liver-related event based on they create this polygenic risk score and hepatic fat content score, and then look at the overall genetic contributor to liver-related event. So if someone with diabetes, a low score, there's no increased risk. However, if someone with diabetes and with a high, what we call polygenic risk score and hepatic fat content, and liver-related event is actually quite high, 3 times as high. So the same with obesity. However, if they have no metabolic risk factor, those gene score don't contribute to any increased liver-related event. So it's quite interesting. Having the genes but no metabolic risk factor, they don't suffer from the consequence of having those genes. But if they have any metabolic risk factor, liver-related events will go up proportion to how many genetic abnormalities the person might have. So genes do play an important part. And obviously, when you have many things come together and the lifestyle change in the last 10 to 20 years, now we are seeing the age at diagnosis of someone with significant fibrosis at a much younger age, and they progress to liver failure at a much younger age. In fact, now we are doing liver transplant on someone with MASLD cirrhosis when they're in their early 40s. And that's dramatically different from in the past. They don't develop cirrhosis until they're in the 60s. So this would significantly impact the society life expectancy and the liver-related events such as cirrhosis and liver cancer. So what are the challenges in assessing patients with steatotic liver disease or MASH from primary care perspective? So the challenge is most of the patients don't have any symptoms. In fact, majority of the time, the metabolic associated steatotic liver disease or MASLD is being discovered by chance. And obviously, fatigue is a common symptom for a lot of reasons. And there are incidental findings with either because of abnormal liver enzymes or someone with dyspepsia, they get an ultrasound and the report is someone has fatty liver, or on physical examination, the liver might be enlarged. And so very commonly, our physicians do routine physical examination because of concern about weight, dyslipidemia, or statin monitoring, diabetes long-term monitoring, and once in a while they are being discovered by medical insurance or occupational health check. So majority of people don't go to see a physician complaining that I have a fatty liver and can you do something for me? So the challenge is a lot of younger patients particularly don't seek medical attention even though they have MASLD or even MASH with fibrosis. And a lot of time the liver tests don't look very bad. And the physician don't appreciate how serious the liver status might be. And for that reason, a lot of time the cirrhosis is being diagnosed very late and being referred to as a stage. The opportunity to change natural history is more limited. So abnormal ALT is very common. Majority of time is due to fatty liver. After all, 1 out of 3 or 4 adults having fatty liver, and very likely they would have abnormal ALT. And for many years, healthcare practitioners really faced with this, a lot of abnormal ALT, and very likely they were going to rule out Hep B, Hep C, and most of the people are very well, and the ALT is only mildly abnormal, and it become a challenge to refer all of them or refer none. And typically, the rejection rate is very high, so there's also the impression that we don't want to see them. And or even if we accept them, the wait time for abnormal ALT to be assessed by a specialist will be over 1 year. And from a specialist perspective, and definitely we don't have the capacity to see all of them. And we accept majority would be MASLD. And for many years, we don't have very good treatment, but this is changing now. And still now there's a lot of rejection rate. So this is just give you some idea about other common liver diseases. 1 out of 3, 1 out of 4 adults will have MASLD. 1 out of 20 will have MASH, and 1 out of 100 would have significant fibrosis due to MASH. Now, alcohol liver disease prevalence is increasing, especially during the last 5 years and the COVID pandemic. Genetic hemochromatosis is 1 out of 300 Canadians, but the penetrance is highly variable. And autoimmune hepatitis is 1 to 20 per 100,000. PBC is 20 to 30 per 100,000. Wilson disease 1 per 30,000. PSC is 1 per 100,000. Alpha-1 antitrypsin deficiency is 1 to 1,500, but the penetrance is also highly variable. So as you can see, majority of your abnormal ALT is due to fatty liver. So the classic medicine approach doesn't really work for MASLD management. The classic medicine approach would be someone presented with being unwell and a disease condition that they have symptoms, and that make them to seek medical attention from primary care physician. Primary care physician would have a suspected diagnosis, but to confirm that, they would send the patient to see a specialist, and there would be further testing and follow-up or treatment. So because abnormal ALT or MASLD is so common, you really have this bottleneck effect and a high wait time in order for the patient to have a diagnosis or a treatment plan. So this really doesn't work very well for the traditional medical approach to having a disease first and then do something about it. So as you can see, you see this slide before, none of them would have symptoms, even when they have cirrhosis. Abnormal ALT, and in general, they do have mild abnormal ALT. However, the ALT could be normal also. Ultrasound could be normal or just said echogenic. And albumin, INR, bilirubin, they would be all normal, even when someone has early cirrhosis. Obviously, we need a better way to helping us to select the patient that they need to be seen by specialists, and they need to have more intense monitoring and treatment. So as you can see, we really want to identify patients with F3, F4 if we can. And obviously, if we have tests very sensitive, they can diagnose F1. That doesn't help very much. We have a lot of patients. And the concern is once the disease is above F3, that's when the severity of the liver disease will start, and liver-related mortality will start increasing. So somehow we have to find a way to identify patients with at least F3 fibrosis in order to really allow us to attempt to change the natural history and improve the liver health. So, and that's what we need to do, is really identify the F3, F4, and then we'll be much more efficient in seeing them and do something to help them. So in 2016, we actually have a MASLD program, or at that time we call it Steatosis Assessment Fibrosis Evaluation Program, that started in 2016, run by a nurse. And the goal is to really efficiently and effectively assess liver patients for primary care physicians, and then identify the right patients to be seen by hepatologists. And the priority of the appointment would be based on this assessment. And our goal is to try to improve wait time to see hepatologists. And hopefully the program is really something that can be reassuring to the patient and to the referring physician. And it's also allow us to monitor the progression also. The goal is really to improve liver health. So that's the beginning of the Alberta provincial pathway. And the goal is really, if you can identify early, maybe you can change the natural history, prevent progression from fibrosis, early fibrosis to cirrhosis and liver failure. So this is what we call proactive approach, finding opportunity to improve health, not only just the liver, but overall health. So now I won't go into this, but so the next part of the talk will be on non-invasive tests to assess MASLD or MASH patient with fibrosis. And what we want to do is really identify them so we can either monitor them or they get further assessment. So the non-invasive tests to diagnose liver fibrosis are here. They could be very simple, like the AST platelet ratio index, FIB-4 index, NAFLD fibrosis score. And the FIB-4 is very easy to do. In fact, in Alberta now, you can actually order FIB-4 directly, and it will give you the score and what does that score means. So those are proprietary tests, and unfortunately, they are not supported. ELF is available if you call the lab for whatever reason you want to get this test done, and the lab might approve it. And then we have imaging study, and in our clinic, we use a lot of FibroScan, but elastography can be available in MR format or ultrasound format. And obviously, there's an increasing wait time and cost to the test. So APRI is something you know, and we have decided not to use it because it's not as sensitive or specific enough. So what we actually elect to do to look at two score. One is the FIB-4, which is very easy, based on age, AST, ALT, platelet count. And the NAFLD fibrosis score is very similar, except you have to add in BMI, albumin, and whether they have impaired fasting glucose or being diabetic or not. What is important for us is the FIB-4 score. If they have less than 1.3, the negative predictive value for F3 or above is actually very good, 90%. It's not perfect, but it's very good. And hopefully over time, if we miss some fibrosis, you will get picked up in another year or two. So this score can be done very simply, and you can repeat them as frequent as you want to. But in general, it shouldn't be repeated more than once a year, or as the disease don't change so suddenly. So the enhanced liver fibrosis score, or ELF, is based on collagen turnover or fibrosis turnover in the liver. And if the score is less than 9.37, it has also a very good negative predictive value also. So there's also something called liver safe score. And again, it's very much the new kid on the block. And again, based on age, body mass index, diabetes, platelet count, AST, ALT, and the globulins, which essentially in this study is serum protein minus albumin. And if you go to different calculator, this is from Stanford, and you can actually calculate a score. This is a lot more sensitive than the FIB-4. You would identify anyone with stage 2 or above fibrosis. So it's a little bit more sensitive and better than FIB-4. However, that means you would need a lot more resources to look at the F2 in addition to assessing the F3 or F4 patients. So this is actually, I included this to show you what the FIB-4, the safe score, and the NAFLD fibrosis score means. So if you have an elevated low-risk FIB-4 score versus high risk, and you can see the overall mortality will increase over time. And If you look at cardiac, there's no additional information you can get from that. But if you look at liver-related outcome, and as you can see, high FIB-4 would predict higher liver-related event compared to your low score. And in fact, FIB-4 can predict risk of cancer also. If you look at the non-alcohol fatty liver score, and again, is not as good, but if you look at liver-related, it does separate the, if you look at the low-risk score versus the high-risk score, it does provide information who will likely develop liver-related issue. But it's not as good as looking at extrahepatic malignancy. The SAFE score, as you can see, much better. The low score versus high score can give you the overall mortality difference and cardiac event, liver-related event, extrahepatic malignancy. So that's a score really might come into practice in the future as we can collect information easier and provide a score to you. So what I want to really, after seeing all those things in clinic, there's certain things really useful for you. Yes, in early liver disease, the ALT is always higher than AST. As the liver disease progresses, you see ALT coming down, AST going up. That's when you realize that the liver disease is much more severe. And whenever you see AST are higher than ALT, and you should be concerned about it. So this is the normal range of platelet count. As you can see, the platelet count can stay at normal range until they become overtly cirrhotic. So when early F4, you might see your platelet count still within normal limit. And in general, when the platelet count less than 175, you should be pay more attention to it. Most of absolutely normal platelet count should be around 200 or above. When you look at the MCV, it's gradually increasing. In alcohol liver disease, this increasing is much more dramatically. When you look at IgG and IgA, they tend to increase as the fibrosis become more severe in MASLD. So those will be very simple way for you when you look at your laboratory results. They might help you to determine who you should calculate the FIB-4 score and see whether they need the second step testing to confirm the liver fibrosis. So in our clinic, we do the transient elastography or VCT, vibration control elastography. It takes about 5 minutes to do. It measures how soft the liver is. And when the liver is very soft, and once you damage it, it gets hard. And it also provides how much fat information, how much fat in the liver from normal to severe. So it's a very simple test that we can do at bedside. And again, the VCTE is very good at the both extreme. A low score is very good at ruling out F2 or below fibrosis. A very high score is very good at confirming someone might have cirrhosis. In between is not very good. So, but what we are using is really for the negative predictive value. When you compare the gold standard elastography, which is MRI performed elastography versus FibroScan, and if your intention is really to separate it stage 2 to 4 from 0 to 1, the performance is essentially no difference between FibroScan and MRI elastography. Again, if your intention is to distinguish 0 to 2 from stage 3 to 4, and VCTE is really not that bad compared to MRI elastography. However, if your goal is really distinguish any fibrosis from no fibrosis, obviously MR elastography is a lot better. So the fibrosis state is important in the natural history, and you see that before. So in our pilot pathway, this is not the provincial pathway, this is at our pilot pathway. And in the next talk, I will explain why we changed our pilot pathway in the provincial pathway. And essentially anyone with FibroScan or VCT greater than 8 kilopascal, or we could not perform the measurement, and they would get formally assessed in the liver clinic. So this is our liver unit study and statistic done by Dr. Juan Abrados Gonzalez. And in our pilot study, we confirm a 1.3 score is a very good negative cutoff test. And the probability someone has significant fibrosis if the FibroScan is less than 1.3 is quite low. So, and in our pilot study, if we follow a FIB-4 first, and if the FIB-4 is abnormal, they get a FibroScan. 87% of the participants in this study don't need to be seen by hepatologists. Only about 13% will need a FibroScan, and 4% actually need to be seen by hepatologists. So look at this. This is actually my own clinic. The wait time was increasing, and it was almost a year when we have to, if we accept someone with abnormal ALT, once we started the pathway pilot project, our wait time for abnormal ALT dropped. It's also helped the medium priority and slightly improved in the high priority also. So back to the two cases. The first thing should tip you off is the AST is higher than ALT. The platelet count still normal, but less than 175. If you calculate the FIB-4, it's actually 2.77. If you calculate the SAFE score, it's a high risk for significant fibrosis. In this case, the patient has a FibroScan, and the measurement is 12.2 kilopascal, and that will suggest significant fibrosis. In this patient, although the ALT is higher, and the FIB-4 is actually only 1.20, and the SAFE score, because it's much more sensitive, it will give you an intermediate risk, and the FibroScan is less than 8, means no significant fibrosis. So this is the referred pathway, and I'm going to go over that next time. And so the managed patients with obesity or MASLD really cannot be just physician. And it's very complicated if you just involve physician alone or medical therapy using medication, and it's not going to work very well. It does require a multidisciplinary approach. You have to quarterback the primary care physician. You have dietitian, nurses that help you to manage diabetes or monitoring your patient, support group, activity trainers, and you have hepatologists, endocrinologists, bariatric surgeons. There's a role for clinical research. And next week, I'm going to explain why the clinical research is actually part of this group that will improve care to MASLD patient or obesity patient. You have to also address their anxiety, their depression, and the overall health service will have to be part of it. And for that reason, we won't be very successful, although the immediate cost is low, but future cost is high if we don't change anything we do. And for that reason, and we really need to get Alberta Health Service to be part of it in order for us to be effectively and efficiently managing patients with obesity and MASLD. So the take-home message, MASLD and MASH are very common, and the principal driver is really the increase in the visceral adipose tissue. And this is the new definition for obesity. And the prevalence is really associated with many things, not just genetic behavioral, but there's a role in the how society really looking at health and looking at diet and many other issues. And the government policy will all dictate how bad the prevalence will become. Advanced liver fibrosis is really a marker for liver-related event and overall mortality. And the cancer risk will include GI, breast, gynecological cancer. Early identification of MASH with significant fibrosis is important and give us an opportunity to improve liver health and overall health. And next week, we're going to talk about how to use the NAFLD or MASLD pathway to guide assessment and refer for further management. I'm going to stop here.
Okay, thanks so much, Mang, for that lecture. I'll just get the slides, please, put up. Thank you. So if you can fill out the evaluation, that would be fantastic. Your feedback's really important to getting the best programming out for you. So just take a couple minutes if you can and do that. Thanks for putting some questions into the chat, and we'll go over those in a second. And towards the end of the program here, I will just talk a little bit about reflection. So maybe let's go to questions first. Mang, there's a few questions that have come in.
Okay.
Janet's asking, when you say common liver diseases have been ruled out, can you tell us which ones have been ruled out?
So I will talk about that next week about the pathway. In essence, there's in the referral pathway, there's actually a test. In fact, we're going to try to convince Alberta Health to really put into practice. There's a panel you can order from the primary care office. So essentially, you rule out viral hepatitis B and C and rule out autoimmune disease, look for genetic hemochromatosis and the common liver diseases. So that's what I guess a panel of tests that we have developed, and hopefully that can be part of primary care panel that you can order without you check every single box in it.
Okay, awesome. Is there an age limit for using the FIB-4?
Okay, there's a debate to it. So I think it depends on how sensitive, how specific you want it to be. And there is a paper from us coming out for age 65 or above. A score of less than 1.3 is still very good. And but there's some studies suggest that FIB-4 of 2 might be better in the age group of 65 or above. So, and the issue is what you want the test to be, a good negative predictive value or a test to be more sensitive. So if you want to, a FIB-4 of 2 can be something you can use in, because age is part of the important parameter in the calculation of FIB-4. So as someone gets older, the FIB-4 will get higher. So, but if the FIB-4 is still less than 1.3, you're very reassured that 66-year-old person would not have significant liver fibrosis. If they have a value of 2 or less, probability they don't have significant fibrosis is also pretty good.
if they're over 65.
Yeah.
Yeah. Okay. Then another question about the tests, and I know you'll be going over that next week, but I'll just mention it. Should the following tests be ordered for all patients to rule out other causes of liver disease? Antimitochondrial antibody, anti-nuclear antibody, IgG, celiac disease screen, etc.
So it's interesting that discrepancy in many different societies. For instance, there's the recommendation for screening celiac disease, you shouldn't perform that in general population. So you're going to see a lot of slightly positive anti-TGG. So, but the initial pathway is that unless the disease has a prevalence of higher than hemochromatosis, we shouldn't be doing it. But that has been ruled out by the panel of experts that, so in essence, the panel would include something like a Wilson disease, alpha-1 antitrypsin deficiency, and other diseases. And but in reality, the majority of time, the probability you pick up Wilson alpha-1 antitrypsin deficiency causing liver issue is actually quite low. But currently, and you still have to do the whole panel. And the only thing really important is real viral hepatitis, because it does carry public health risk. And there's also a good treatment out there you can do to change the natural history. So viral hepatitis for sure. The rest you can do, but it all depends on your certainty if someone has fatty liver or not. So in the right setting, pretty much that normal ALT is due to fatty liver.
Okay. Then just about the AST rise. So in the case presented, doesn't AST also rise faster in alcohol-associated liver disease? And how does that confound the FIB4 calculation?
Yes, it doesn't work on alcohol liver disease. So the ratio of AST to ALT is high in alcohol liver disease is really related to nutrition. So when we measure AST, ALT, we are actually not measure protein concentration. We are measuring enzyme activity. That's why they call it liver enzyme. And in alcoholic, they rather drink than eat healthily. So they're deficient in pyridoxal phosphate. The more severe the alcoholic is, the lower the ALT. So when you see someone with AST of 200, ALT of 16, you guarantee you're seeing someone with alcohol liver disease. And but yes, someone with the combination of met alcohol and the alcohol part might contribute to very high FIB4, and hopefully the FibroScan will further clarify whether this high FIB4 is due to fibrosis or just a lot of alcohol consumption without significant fibrosis. Not FIB3 alcoholic actually get cirrhosis, but
And
they
then,
get fatty liver.
oh, sorry, Ming, and a follow-up to that, what level of drinking precludes one from using FIB4?
So if you, first of all, occasional alcohol use doesn't change anything. And it's not clear about occasional binge drinking. But in general, if you consume one drink per day, you shouldn't change the FIB4. And in the new Canadian guideline, there's actually no safe limit of alcohol use. So if someone consistently drinking more than a couple of drinks, they probably drinking a lot more than they admit. So alcohol consumption is a challenge when you ask people to recall how much they drink. When they say they have a couple of drinks per day, very likely would be much higher than that. And for that reason, your FIB4 score can be impacted by this a lot more alcohol use.
Okay, and I'll just squeeze in one more question, Ming. Should all patients with obesity, hypertension, hyperlipidemia, diabetes have their ALT, AST, and ultrasound done to check for MASLD?
Yes, that's the new guideline for the American Endocrine Diabetic Association and Endocrine Society also. And as I mentioned to you, is those patients, the prevalence of fatty liver is much higher than the general public. And for that reason, doing the AST/ALT would be important. Not to mention, if you're using statin, you need to monitor AST/ALT anyway.
Okay, there's a couple questions about the pathway, but we'll cover that next week, and including any other screening tests, and then some kudos to you for a great presentation, Mang.
Thank you.
Okay.
So hopefully, what I present to you is something useful in your day-to-day clinical work. And so two things you should watch out for is the MCV. Anytime when your MCV over 95, pay attention to that. And AST higher than ALT, and the platelet count less than 175,000. So those might be marker that your FIB4 would be high. And do use the FIB4 check, and you can do the FIB4 directly. You don't need to order the test that you need to use to calculate the FIB4.
Okay, excellent, Mang. So I'll wrap up here with for those of you who can stay on, just the last little bit about the L3 program, and just a reflection on what you've learned today and how you might implement all of those great things into your own practice. And the Office of Lifelong Learning and the Physician Learning Program Office has prepared a platform to help you make a personal development plan, which can also help you earn credits, and it's free to access. The link is going to be placed in the chat box here by Natasha. And the L3 plan is a free online tool, and it can help to support the 3 activities and action plans required by the CPSA's Physician Practice Improvement Program, which are practice-driven quality improvement, personal development, and standards of practice quality improvement activity. So all of that information you can get at the QR code there and the link that's in the chat. Upcoming programs. So we've got the part 2, of course, of the fatty liver on February 4th at noon, and part 2 of Beyond Blood Sugar program on February 11th at 8. And thank you to Dr. Ma, and thank you, of course, to everybody who's attended for your participation. Okay, take care, and we'll see everybody next week for part 2. Thanks, Nandi.